So my name is Hannah Kuper, and I'm from the International Centre for Evidence in Disability, which is at the London School of Hygiene and Tropical Medicine. I'm going to give a bit of an overview about global childhood disability. And as you can see on the first slide, there is our web address, and I've included that because a lot of the information that I refer to is on our website. So if you want to see things in more detail, you can find them on our website. So the first question is, how many people in the world have got a disability? And the best information that we have comes from the World Report on Disability, which was produced by the WHO and the World Bank. And it estimated that overall about 1 billion people in the world have a disability. So that's about 15% of the people in the world. And the same group also estimates that there are about 95 million children with disabilities in the world, which is about 5%. Now, in looking at these estimates, you have to bear in mind that there is actually very, very little data on the prevalence of childhood disability, and that these estimates were extrapolated from other sources of data. And a different group who looked at how many children may or may not have disabilities was UNICEF in their State of the World's Children report. And what they concluded from that was this nice quote of, global estimates are essentially speculative. So that there's lots of uncertainty as to how many children there really are in the world with disabilities. So our group at the London School of Hygiene is working very much around evidence. So what we're trying to do is to provide evidence so that NGOs and policymakers and program implementers can do their work better. And one of the fundamental pieces of information is how many people have disabilities and what the types are and who's most vulnerable. So we've tried to do work around that. And I'm going to present 3 different pieces of information and then give an overview. So the first thing that we do is surveys of childhood disability, and we've recently completed 2, one in Cameroon and one in India, where we've looked at childhood disability both by the presence of an impairment, like whether or not a child has got a vision impairment or a hearing impairment, as well as if there is self-reported difficulties in functioning. So we took a very broad view of disability. Now, what we found overall is that for people under 18, in India about 3.5% had some kind of disability, and in Cameroon it was closer to 5%. So between 1 in 30 and 1 in 20 children had some kind of a disability. And for those surveys, we went door to door and we selected children in the community and then screened whether or not they had a disability. Now, childhood disability can be relatively rare. So although we could get an estimate here of the prevalence of disability, we didn't have vast numbers of children to be able to say lots more about them. So we've also explored a different way of doing surveys, which is through the key informant method. So in surveys, you go door to door and you identify children and you see whether or not they may have a disability. And in the key informant method, you do it the other way around. So we train key informants in the community who identify children who they think may have a disability, and the children are then assessed by clinicians or experts to determine whether they have a disability and the kind of disability that they have. And so what you can get through this method is a much larger number of children with disabilities that you identify. But what you're restricted to is that you end up identifying children who have got more serious impairments. So if a child doesn't have a very severe impairment, they are unlikely to be identified by the key informant. So it's just a different way of looking at childhood disability. And we've conducted these now in 4 settings, so in Bangladesh, Pakistan, Kenya, and Malawi. And in each of these, we've identified usually thousands of children with disabilities. And we find that the prevalence is about 1% overall. So it means that about 1 in 100 children identified in these communities may have a more severe disability. And if we look at the types of disabilities that they have, This is by physical, hearing, vision, intellectual, or epilepsy, just bearing in mind that we only started looking at intellectual impairment in the 2 African sites. We find consistently that physical impairment is the dominant type in children. So that of these 1% of children with more severe disabilities, the most common cause is physical. So that's the second piece of evidence. The third piece of evidence I'm going to present comes from Plan International. So Plan International has got a Sponsor a Child program, which it runs across 50 countries. And it has about 1.5 million children who it sponsors, and each of those children are interviewed every year. And a couple of years ago, they asked, so they work across these countries, and a few years ago, they asked the question of those children, does the child have an impairment or medical condition that can lead to disability? So what you can imagine is that this kind of question is not going to pick up children who have milder disabilities. So it might restrict it to the more severe cases with disability. And what they found overall was that there are about 1% of children identified through this route had some kind of a disability, and this shows the numbers across different countries. So through this method, again, it confirmed this result from the previous studies that about 1% of children in these settings may have a more severe disability. The other thing that was interesting in this plan data is that we could start comparing between boys and the girls. So, for instance, this shows the relationship between disability and gender. Now, what you see on this axis at the top is an odds ratio. So, if the odds ratio is 1, it shows that there is no relationship between disability and gender. If the odds ratio is above 1 here in this section, it shows that disability is more common in boys. And if it's below 1 here, it shows that disability is more common in girls. So for this estimate for Paraguay, it shows that disability was 1.7 times more common in boys than in girls. And for those who are statistically minded, it shows that it's statistically significant because that confidence interval does not include 1. And if we look across all of the countries, we find the same result in all of the settings pretty much. So across all of those different settings, disability was more common in boys than in girls, which is plausible given that boys often also have a higher mortality rate than girls. So putting all of those pieces of evidence together, what we find is that maybe between 1 in 20 and 1 in 30 children in a low middle-income country have a disability, and that for 1 in 100 children, those will be quite severe. The leading cause appears to be physical impairments, and overall disability appears to be more common in boys than in girls. So that's just to give a very broad overview as to what the situation is with childhood disability. The next question is, what does this mean in the lives of the children and their families? So what is the impact of disability? And I've tried to highlight a couple of key ways in which disability impacts on children's lives. So the first key way is with respect to education. So going back again to the data from Plan International, we could compare school attendance between the children with disabilities and those without. So here we find, as an example for Indonesia, 95% of the girls without disabilities went to school. In comparison, that was about 48% of the girls with disabilities. So how we define disability in this case was through that plan definition, so self-reported impairment or medical condition leading to disability. And so what it meant is that the girls with disabilities were more than 20 times less likely to go to school compared to the girls without disabilities. And if we look in Indonesia at the boys, we find that the boys with disabilities were 10 times less likely to go to school compared to the boys without disabilities. So remembering that 21 statistic, so here this is Indonesia for the girls, so they were 21 times less likely to go to school. And if we look across all of the countries, we see a very strong relationship between having a disability and not going to school. And we see it in all the countries, so that overall, on average, the girls with disabilities are about 10 times less likely to go to school than the girls without disabilities. And if we look at the boys, we see the same. So a very strong relationship between disability and exclusion from school. Still looking within the plan data, the children were asked why they didn't go to school. And impairment was reported as the main barrier. So the children were saying they were not going to school because of their impairment. So this meant that the schools were there, but that they were not getting into the schools. The schools were exclusionary. For the children with disabilities who were at school, they were on average at a lower level compared to children of the same age without disabilities. And this varied a lot by impairment type. So the children who seemed to be most excluded were those with communication or intellectual impairments. So again, it was pointing to exclusion on the part of the schools rather than that the schools weren't there. And this is an extremely big issue because exclusion from education has a huge impact on the life of the child. What children with disabilities want is the same as all other children, is to be with their peers, to play, to go to school. It has an impact on the carers who may need to be at home with the child with disability if they cannot go to school, and it has a long-term impact on that child's employment possibilities into the future. So one very clear impact on disabilities on exclusion from school. Another clear impact which goes along with this is on health. So again, looking at the plan data, we find that the boys with disability here, again looking at Indonesia, were about 6% of the boys without disabilities reported having had a serious illness in the past year compared to 21% of the boys with disabilities. So they're 4 times more likely to report a serious illness. And the girls, similarly, they were significantly more likely to report a serious illness. So here's the figure for Indonesia, and if we look across all the countries again, you see a very clear trend that children with disabilities were more vulnerable to having serious illnesses, which were often unrelated to their disability. It was other things like malaria or flus and so on, serious. And the same thing was true among the girls. And in qualitative work that we've done, it shows that this serious illness is often a reason why the child is not going to school, so that those become part and parcel of the same thing. We can look in terms of the impact of disability on poverty. And it's often said that there's a vicious cycle where poverty makes children more vulnerable to developing disabilities, either that they're more at risk or they're less likely to have treatment, and that children with disabilities the disability may increase the poverty of the family through reduced employment opportunities or the costs incurred through need for more expensive transport and assistive devices and so on. And there is evidence for a strong link between childhood disability and poverty. So we did a systematic review, and this shows the 15 studies that looked at the relationship between disability measured in different ways, whether it was vision impairment, hearing, physical, cognitive, or general disability in different countries, and their association with poverty. And what this final column shows is that the first study in China showed an inverse association, so that the children, in this case with myopia, were actually less likely to be poor, and one study showed no association, but the remaining 13 studies showed a statistically significant increased risk of poverty among the families where a child had a disability. So this is an extremely strong effect. And the final example I want to give is similar. It's with respect to malnutrition. So similar to the cycle between poverty and disability, people talk about a cycle between malnutrition and childhood disability, where children who are chronically malnourished may develop specific conditions or developmental delay, which leads to childhood disability, conditions like rickets. and that children who have disabilities may become more malnourished because they're poorer, because they have feeding difficulties potentially, or more negatively because of poor care or exclusion or frequent illness. And again, we've done research into this, and we found this to be the case. So we did a study in a very poor area in Kenya called Turkana on the relationship between disability and malnutrition. We looked at underweight children with disabilities compared to a sibling in the household and compared to their nearest neighbor, and we found that the children with disabilities were more than twice as likely to be underweight compared to their sibling, and 2.7 times more likely to be underweight compared to their neighbor. And if we look at other measures of malnutrition, stunting and low BMI and wasting, we find the same thing. So others of the limited data that others exist also shows that that there is probably quite a strong relationship between childhood disability and malnutrition. So putting that all together, we see a very widespread impact of disability on the lives of the child, but also there is a large family impact of disability. So the impact on the carer and the siblings and so on, both emotionally and in terms of time spent in poverty. So disability is often experienced at the level of the family. So what are the priorities for action, putting all of this together? Well, one clear thing is that there's in low middle-income countries, there is often a large treatment gap, so that children with disabilities will often be able to benefit from treatment. So whether this is for instance, here, cleft lip, or to give hearing aids, or other kinds of devices, or rehabilitation. So there is a large medical need which often exists, and where children and their families can benefit a lot. And this obviously is constrained by resources and skilled personnel and so on. And we might need to think of new innovative ways for providing treatment in these settings. Uptake to treatment is often also an issue, that even when children are offered treatment, it is not in the right way or acceptable, so we need to think of how that can better be done. But treatment and health is just a very small component of the impact, and I talked about this very widespread impact of disability in the lives of the children and their families, not just on health, but on things like education and poverty, and the family in general. And we need to think also as to how to address those issues to improve the quality of life of the child with disability and their family. And one useful model for thinking about this is through community-based rehabilitation. So this is the community-based rehabilitation matrix, which is promoted by the WHO, and it looks at different components where interventions may be helpful for a person with disability and his or her family. And you can see that health is one component and an important component, but that there are other things that also need to be considered, like education, livelihood, social and empowerment, and that there are different suggestions for action within that. And the point of CBR is very much to offer services that are appropriate in the local setting at low cost. And it doesn't mean that each of these components is needed for every single person with disability, but that it's useful to think what might be needed. So for instance, for a child with a hearing impairment, they may benefit from an assistive device, which is in the health component. They may benefit from assistance with inclusion in education, down the line improvements in skill development, or help to find jobs may be useful, and so on. But it doesn't mean that everything is needed at this point. And I think that Hitomi will probably talk more about this. Actually, the delivery of these services is a whole nother kind of question as to how that is best done, and whether services need to be targeted specifically for children with disabilities, or and or whether there should be more of a focus of including children with disabilities within mainstream programs. So for instance, in the study that we did on malnutrition in Turkana, one of the issues that we saw was that many of the children with disabilities weren't going to school, but yet the famine relief programs were operating through schools, and so they were being excluded from those, which may have enhanced their malnutrition. So it's called a twin-track approach, whether you focus on mainstreaming disability within ongoing programs or targeting specific programs at people with disabilities. So just as a conclusion, I wanted to finish by saying childhood disability is very common. So if you look at any kind of disability in a low middle income country, it's probably between 1 in 20 and 1 in 30 children. If it's more severe disabilities, it might be 1 in 100. That disability has a very wide-ranging impact on the life of the child and his or her family, so looking beyond health at education, poverty, malnutrition, and so on. There is a very large treatment gap, which means that children with disabilities may often benefit from medical interventions, but that is not going to be enough, and that because of these wider needs of children with disabilities, programs also need to target other dimensions of life like education and social and so on. Overall, there's a very poor evidence base around childhood disability in terms of how common it is, what the needs are, and so on. And that's very much where my organization tries to contribute by doing more research, but an enormous amount more is needed. So I wanted to finish by saying thank you very much and highlighting again our website here. So if anybody wants to contact me or wants to find out more information, a lot of it is on our website. Thank you. So Sean, would you like me to go through these lists of questions?
Yes, please do.
Okay. So how are the key informants assessing disability? So what happens is that the key informants identify children in their community who they think may have a disability, and that the children are then brought to a screening camp where they are clinically assessed by a range of clinicians to see if they have an impairment. So having hearing tested, vision tested, and so on. Is physical the most dominant disability because it can be seen? How was this assessment made? Again, there's a big lack of evidence. That's an interesting question, and part of that is that children with disabilities often have multiple impairments. So let's say a child with cerebral palsy may have a physical impairment but also an intellectual impairment, and it might be designated as being a physical impairment because that's the easiest to assess. However, overall, I'd say that there's a very widespread evidence that physical impairment seems to be the most common type. So my feeling is this is probably real. How do we define disability in this case? That was during the presentation of gender disaggregated data. So that was self-reported by the parent of the child in the plan data. As you probably know, in many countries, children with disabilities are institutionalized. Did your surveys count those children in your totals of 1 out of 20 or 30? So the answer is no, they did not. And so that is going to be a limitation. However, the children with disabilities who are likely to be institutionalized are children who have more severe impairments, and that's going to be a smaller portion of the total. And so it's still likely that these estimates are likely to be more or less accurate, given the limited data. So was there another set screen with questions? So what strategies do you think can be used to integrate persons with disabilities into schools towards getting an education? So that is a fantastic question. And the answer is, as far as I know, we don't really know. I think a lot needs to change on the side of the schools to be more inclusive, and the teachers to be more confident in being able to include children with disabilities, as well as helping children with disabilities overcome their barriers in getting to school through transport and so on. So I don't think it's going to be one magic bullet. I think it's going to be a case of identifying the barriers on both sides and how they can best be overcome. what are the social protection mechanisms can be used to safeguard the lives of children with disabilities through their carers and parents? So this is an area that we're actually working on quite a bit at the moment in terms of inclusion of people with disabilities in social protection. There are quite successful programs in South America where where children with disabilities, that family should be automatically included in a social protection program. It's an entrance criteria, and that seems to me to be a very good idea. In developing countries, we don't have properly trained teachers and school facilities for children with disabilities. How is Plan other organisations dealing with this challenge? Well, as I kind of referred to earlier, I think there is a lack of data or consensus as to what best needs to be done, and this is a very important area for more research in the future. That different people are trialling different things which seem to be working, but there's no clear consensus about what needs to be done. But these are very much my opinions. I'm sure that there are many people in the audience who have different opinions or different thoughts. Are there any other questions?
We had another question that came in while you were talking.
Okay.
They would like to know if you included children with functional disability like sickle cell diseases in your survey.
They would have been captured if they had an impairment. So the sickle cell is the disease or health condition, and that might affect functioning, so ability to walk or so on. And if it affected functioning, they should have been captured by our study.